All right, guys, so this is our sensory and perception project on the phantom limb. And this is our clinical introduction by Ela.
Hello, Dr. Alga. Hello, Bridget. Please take a seat right here. Thank you for coming in today. Today we're going to test your sensation following your left arm amputation with the Q-tip. I will use this Q-tip to touch various spots on your body, and you will let me know what you feel and where you feel it with your eyes closed. Close your eyes, please. Feel it on my left cheek and a tingling in my left thumb. I feel it on my left upper cheek and left index finger. I feel it on my left lower lip and my left pinky. I feel it on the right side of my forehead. It seems as though there has been a cortical rearrangement due to your amputated limb, which is known as phantom limb sensation, because you're feeling sensations in your missing limb when I touch certain parts of your face. The brain has a somatosensory cortex, which houses a map of the surface of the body. Sensory information from the left side of the body is sent to the right somatosensory cortex, making it contralateral, and every area of your body has a corresponding area on the somatosensory cortex. The face area in the somatosensory cortex is directly inferior to the hand area. Since there's no sensory information coming from the left side of your arm that was amputated, the somatosensory cortex has reorganized in a way where the face area now extends to your arm to compensate for the lack of sensation in your arm. The neurons from your hand area cross-link and they form connections with the nearest area, which in your case was the face, resulting in somatosensory cortex rearrangement.
So the first case study that we'll be looking at is an experiment called motor and parietal cortex stimulation for phantom limb pain and sensations. So the broad question was, are there certain tools or methods in our arsenal as neuroscientists that we can use to alleviate phantom limb pain? The specific question was, could transcranial stimulation or TDCS over certain areas of the posterior parietal cortex reduce pain from phantom limb syndrome? So the first hypothesis was the long-term effects of TDCS could potentially reverse the modeling that the brain underwent as a result of the amputation and the subsequent phantom limb pain. And the second was the long-term effects of TDCS will not ease the symptoms of phantom limb pain. So in experiment 1, every patient had to do 2 sessions of TDCS. One was a control and one was experimental. In the experimental session, the researchers stimulated the primary motor cortex for 15 minutes by placing the anodal electrode over C3 or C4, specific points on the somatotopic map. The patients were then asked to complete a questionnaire and rate if they had felt any discomfort. In the second experiment, the researchers also tested cathodal in addition to anodal electrodes on the posterior parietal cortex, and here the electrode was placed over the P3 or P4. The researchers found that the intensity of certain PLS symptoms, non-painful phantoms, as well as phantom limb pain, could be reduced by brain polarization of cortical areas associated with plastic remodeling post-amputation. The decrease, however, was not long-lasting, less than 90 minutes. They also found that the different symptoms of phantom limb syndrome are linked to different cortical areas. In the future, more work with larger sample sizes could prove even more beneficial.
Our next case study looks into mirror box therapy and its application for treatment for phantom limb syndrome. This research was done by Desmond et al. And the title of the paper is Augmenting the Reality of Phantom Limbs, 3 Case Studies Using Augmented Mirror Box Procedure. So the questions are the broad question, what are effective therapies for amputees suffering from phantom limb pain? And the specific question is, can mirrorbox/augmented reality intervention help overcome phantom limb pain symptoms? The first hypothesis was augmented mirror box therapy is an effective treatment for unilateral amputees suffering from phantom limb pain. And the second hypothesis was if phantom limb pain experience is influenced by contradictory proprioceptive and visual feedback, manipulation of the association between felt movements and visually presented movements could have therapeutic potential. The methods. A standard mirror box consists of a mirror vertically inside an open box aligned at the midline. The patients place their intact arm on the reflective side of the mirror so that when viewed, it creates the illusion that their amputated arm is also intact. Augmented mirror box consists of three-dimensional graphical representation of an arm on a flat computer screen. In this study, there were 3 subjects, and they were interviewed and asked to complete symmetric and asymmetric arm movements using both intact and the phantom arm. These movements consisted of pronated tapping of the index fingers and simultaneous movement of all fingers with the palm of the hand held facing the mirror. The results suggested that augmented reality offers a promising new approach to investigation of phantom limb experiences and potential treatments. Participants 1 and 3 showed increased sensation of their phantom experiences through augmented reality exposure. The results show that it is possible to remotely or externally induce movements in the phantom limb. Although the sample size was rather small, the results are promising for future development of treatment. And the summary and inferences, the mirror box as well as augmented reality treatments do influence phantom limb experience in some patients. Larger sample size would be preferred.
So the third case study is on the use of prolonged peripheral neural blockade after lower extremity amputation by Borgi et al. So the broad question, what are the potential therapy options to help prevent or reduce phantom limb syndrome or PLS? The specific question, can a local anesthetic continuously infused near the site of amputation alleviate the effects of PLS? So the author's hypothesis is that providing amputees with a continuous infusion of 0.5% ropivacaine might alleviate the symptoms of PLS. For the alternative hypothesis, many other previous studies utilizing analgesics and psychotropics to stop PLS were unsuccessful. Thus, this method using a local anesthetic might not relieve PLS for patients. Altogether, 71 patients who underwent an amputation over their lower extremities participated in this study. The patients had a perineural catheter placed directly before or after their operation, near the amputation site. A pump delivered 0.5% ropivacaine at a rate of 5 milliliters an hour through the catheter. Investigators spoke with the patients up to 12 months after surgery. During these meetings, the patients are asked to rate their stump and phantom limb pain from 0, which is no pain, to 4, which is extreme pain, and say whether they had phantom limb sensations. Infusions of the local anesthetic was stopped around 6 to 12 hours before each meeting, until the patient regained sensation in that area of the body. The treatment was ultimately ended when patients expressed a low pain score, a score of 0 to 1, and did not have phantom sensations for 48 hours. A continuous infusion of 0.5% ropivacaine showed promising signs in helping to treat PLS. So out of 71 patients that originally enrolled in the study, 62 completed it. 94% of these patients gave pain scores of 0 and 1 at the 12-month follow-up, and 39% felt phantom limb sensation after 12 months. It should be noted that only 38 patients completed the study following the proper instructions, and all of them felt no phantom limb pain or sensation at 12 months. So in the future, as the authors state, it would be useful to compare these results against other treatments for PLS, like giving morphine. In addition, the placement of the catheter is very invasive, so other methods to administer local anesthetic should be explored.
So sensation can actually be defined as the registration of physical stimuli from the environment by the sensory organs. Sensory organs are responsible for turning energy from light, sound, and air pressure into nerve impulses, which is actually sensory transduction. Perception can be defined as the subjective interpretation of sensations by the brain. A subjective construction of reality is created by the brain to help us decipher what is going on around us. And examples of that are bottom-up and top-down perception. There are various different things that prevent the conversion from sensation to perception, including external context, heuristics, prior experience with environment, internal state, context, physical, emotional, and mental, and top-down influences and expectancies. The somatosensory pathway can be defined as intricate neural circuitry system that is responsible for responding to changes in body sensation. Sensory information enters the CNS through the brainstem or spinal cord via sensory cranial nerves and sensory peripheral nerves, and then reaches the thalamus. The thalamus then transmits the information to the cerebral cortex. The cortex directs the thalamus to suppress some sensations, and this is bidirectional information with the cortex. The primary sensory cortex then swaps information with the secondary sensory cortex. Experience can change the organization of the brain, and this relates to phantom limb patients. Phantom limb can be defined as any kind of sensation, painful or not, in a non-existing limb, and sensations include burning, cramping, aching, or strong painful sensations to the phantom limb. Due to lack of input from the missing limb, somatosensory neurons move on to form connections with the nearest area around them with respect to the phantom limb. And this is our works cited, and that is it.